So like the participant transfer.
So should we? I had a friend that looked like that.
Move things around.
Reminds me of somebody I knew.
Who was that?
You remember her. She was my first wife. Just kidding. So tell me when you're ready.
The video's not on. We're ready to get started.
Okay. You start. Good afternoon, everybody. My name is Mark Surrey, and I'm here with my partner and co-founder, Hal Danzer. And we're going to chat a little bit today about the question that a lot of people that we see have as to why am I not getting pregnant? And so what we thought we would do is let you all know a little bit about who we are, what we do, and how we can try to answer this question of why am I not getting pregnant? So first of all, Dr. Danzer and myself co-founded Southern California Reproductive Center about 25 years ago. And we did this as a reaction actually to limitations that we were having with the technology of IVF and some of the financing of it with major hospitals and medical centers. And we decided, with the assistance of UCLA and Cedars-Sinai medical centers, to open Southern California Reproductive Center as a freestanding fertility center with its own in vitro fertilization laboratory, which is state-of-the-art, its own reproductive surgical center. And it turns out that the medical centers now use our facility for their IVF lab and their pre-implantation genetic testing, which I think Dr. Danzer will tell us a little bit more about when he speaks about treatment options. So we're very pleased to have been here to be able to serve you guys over the last 25 years or so with a state-of-the-art embryology lab, an on-site surgical center, and endocrine and andrology laboratories that we can use to do hormone tests and analysis of sperm. So our locations where we have all these services were initially in Beverly Hills and subsequently in Santa Barbara and in Pasadena. And so we have enjoyed serving patients in these areas. The Beverly Hills location has traditionally served many of our international patients who come here from all over the world for different services that are available here that may not be in the countries they originate from. So, when you look at laboratories, you sort of wonder, well, what's the difference? And there are some very large differences in laboratory technologies as well as laboratory personnel. all of which contribute to your outcomes as to being better. We have an excellent, experienced, certified PhD laboratory director, in fact, two of them, that use a double witnessing verification anytime a patient comes in for any procedures for identifying their eggs, sperm, and embryos. So a lot of people are concerned, well, how do I know that this is my egg and my embryo? And this is how you know, is that you'll be double witness verified anytime you come here for anything. We have advanced culturing technology that's called blastocyst culturing. That's where your embryos grow to an advanced stage, which are actually it's the stage at which embryos can cause a pregnancy. Some laboratories will transfer embryos at earlier stages because they're not capable of this sort of technology. So it's important to know that. We utilize a lot of vitrification for both fertility preservation and tissue preservation. We do a lot of pre-implantation genetic testing, which is very accurate to make sure that your embryos are genetically normal. And most recently, we've adopted time-lapse video analysis with something called the Embryo Scope, which has actually improved our abilities to diagnose and treat different laboratory issues, as well as improve upon the rate at which your embryos can form blastocysts. So when we think about why all this is necessary, we have to look at why people aren't getting pregnant. And, it's probably most apparent in people who have unexplained infertility, meaning that there's not a blockage, there's not a surgical procedure, there's not a problem with egg or sperm production, but nobody knows why they're not getting pregnant, but they're not. So this is a group of patients who are related in part to maternal age. And when you look at maternal age as a factor in fertility, you see a very dramatic decrease in human fertility as we age as human beings. And in that graph on the left that looks just at chronologic age, we notice that fertility at age 38 is less than half of what it was at age 32. And this is the time that we frequently will see patients. So we want to be able to be proactive, aggressive, and effective in treating them during these years. And when we look at the reason why fertility declines during these years, we look at the percentage of genetically normal eggs that a person produces, and we see how that decreases significantly during the 30s, such that the percentage of normal eggs at 40 is less than half of what it was at 30. And if we look at the natural ovarian aging process, you'll notice that there are not only issues with the genetics of egg production, but also the quality and quantity of egg production. At birth, the ovaries are filled with lots of eggs. At 25, there are fewer. At 50, there are almost none. So this is a process that evolves over the period of time. So our fertility assessment needs to be done quickly and needs to be done accurately, and includes a history review, physical exam, and diagnostic testing, all of which can be done in a visit here with us that should not take more than an hour. in its time. So one of the tests that we like to do is a hormone test called AntiMullerian Hormone. A lot of the women have been led to believe that it's necessary to be on the second or third day of a cycle to check hormone levels, and that's actually no longer true. You can check hormone levels at any time during a cycle, and this particular level, called AMH, is very significant because it's a very good predictor of what we call ovarian reserve, or the ability of the ovaries to make eggs. And you'll notice that that also declines significantly as we age as human beings. So when we look at ovaries at an ultrasound, you can see these little circles that are called follicles. And those are a tissue that can contain eggs. So we can do hormonal evaluations, which is a blood test of some different hormones that give us a lot of good information. For example, people who wonder if they're ovulating, and they say, well, I do these home tests, and sometimes they're positive, sometimes they're negative. If you do a level of a hormone called progesterone after you think you've ovulated, then we know that you have or you haven't from that level. So one of the other things that may be relevant is whether the fallopian tubes are open or not, and that can be easily checked with a type of an X-ray we do here in the office called a hysterosalpingogram. And you'll notice the X-ray on the left side shows normal open fallopian tubes, and the X-ray on the right side shows closed fallopian tubes distally. And that's an abnormality that will not result in a pregnancy. So for guys, we want to get an accurate semen analysis. And in order to do that, we've got to be able to look at the structural integrity of the sperm, not just the number of sperm, but the way they move and the way they're structured. That's called morphology. And so people who do semen analyses and don't have morphology done are really not doing a complete analysis. So I want to introduce to you my partner, Hal Danzer, who is a co-director here. He is an excellent physician. He's our co-founder. He's my good friend, and he's going to tell us a little bit about what type of treatment options this testing can reveal should be done. Hal?
Thank you very much for the introduction. As you can see at the bottom, my grandmother was a midwife in rural Montana. And the things that she had in her armamentarium for gynecologic care was probably some liniments. And here today we have an IVF laboratory where we can put sperm and egg together and help create life. What a change in just 2 generations. So what are the treatment options? Obviously, when we're talking about undiagnosed infertility, where all the testing seems to be pretty normal, but yet the couple is not getting pregnant. But again, our technology is limited to some degree. There are things that we can't assess very well. Does the fallopian tube really pick up the egg every cycle? We do a HSG and says, well, the tube is open, but it doesn't tell us about the function. Does the sperm and egg really get together? The sperm count looks good, but we don't really have a test for that. We don't have a test to know if the sperm really function adequately to fertilize the egg. Then there's some other issues as the embryo implant in the wall of the uterus. That's probably a simpler part of the equation, but we don't have a test for that either. But we know from 20, 30 years of studies that there is a succession of treatments we can use that help people get pregnant when all the testing is normal. And you can see on this slide, talk about, again, these women are on mean of about 37 years. So they ought to have a reasonable egg reserve. And some couples elect to say, well, let's do something, watch for another 3 months or so. The chance of getting pregnant is about 1% if you've been trying for a year and not been successful. We know that for anybody starting out, the chance of pregnancy is about 25% per cycle. That's as good as you can do and Mother Nature can do, probably because of the complicated genetic reassembly of sperm and egg. So a natural cycle, 1%. If you've been trying for a year, that's what you expect for the next a year. Now you can add a natural cycle and take sperm and spin it down and pick out the 20% of sperm that are really good and place those sperm in the uterus. It's like a pap test almost. That'll bump the chances of pregnancy up to 4%. So not a big rise, but it seems to help some. And then the next step up is using a fertility agent called Clomid or Femara. These agents have been available for 20 years plus, and they kind of trick the brain center to put out more follicle stimulating hormone, which essentially creates a better environment for the maturation of the egg. And that will move up pregnancy rates to about 7% per cycle. If that's not successful after several months, sometimes we add some injection of natural follicle stimulating hormone. And again, then you can release, instead of 1 or 2 eggs with the Clomid, maybe 2 to 3 or 4 eggs with the injectable. And again, twinning rates, luckily, are quite low, but again, 10%. So those are kind of a progression of what some couples elect to do with unexplained infertility. If you're not successful in 3 or 4 cycles of these treatments, then many of these couples elect to go on and become candidates for in vitro fertilization. And then again, women at age 37 with IVF, the pregnancy rates could be in that 70-75% range. So everyone says, well, why does that make such a big difference? And how do we do these things? So again, here's a little timeline of what happens using, you see up at the top, Clomid or Letrozole. Those are oral agents, so you take it for 5 to 7 days to sort of trick the brain, so the woman puts out more follicle stimulating hormone. And then we do an ultrasound to see how the ovary responds to that. And once we see that, we can use an small injection of, you see down the bottom, Ovidrel, which is what they call the LH surge. That's the pituitary hormone that creates the final maturation of the egg and the release of the egg about 36 hours later. So once we do this trigger shot, let's say it's Wednesday night, then the egg is going to be released on Friday morning. And that's the time where we really schedule for this intrauterine insemination. So the partner brings in a sperm count or gives a sperm specimen here, and takes about an hour to spin it down. You can see at the bottom how they use these, what they call gradient washes, to pick out the best swimming sperm. It's only the strong swimming sperm that are ever going to find an egg and burrow through the coating and fertilize that egg. And you can see at the far right, there's a little small catheter. It's almost like a pap test. Very simple. There's no pain involved. And once you put the sperm in the top of the uterus, it's really halfway where it needs to go to find the egg. And again, that's the benefit of picking out the best sperm and give them a head start. And then once you do the insemination, you go home 15 minutes later. You don't have to go to bed afterwards, but it does seem to help pregnancies to some degree. So in the next slide, then we say, well, everybody wants to know, how complicated is IVF? How long does it take? And generally, it's about 4 weeks. And the first 2 weeks are birth control pills, which sounds counterproductive, but starting on day 2 or day 1 of the cycle, we do an ultrasound. We see how many follicles we have to work with in a given cycle, and that may vary from month to month. But given the ultrasound results, we usually do the birth control pills for 10 to maybe 14 days. And what that does is get the ovary quiet. because the ovary is continually recruiting groups of follicles, eggs, and what you want to do is get them all lined up and synchronized so that when you start the stimulation, they grow in unison. You don't want to have a few eggs that are mature and another group that are immature. We can't work with immature eggs. So we start injections of follicle stimulator. And after 4 days, we do an ultrasound and a blood test. And again, on day 6, 7, or 8, 9. So there's about 5 ultrasounds, how we watch the follicles grow. And the size of the follicle tells us that the egg is mature at some point. And then once we have a group of mature eggs, we do, again, a trigger shot and then schedule the retrieval of the eggs, again, at 36 hours later, which is done with ultrasound with a very light anesthetic, propofol, like they use for dental work. It's a very good agent. Usually you wake up right afterwards, very little nausea, and most are able to manage the cramping afterwards with just Tylenol, and most go back to work the next day. So today we try to streamline the process and make it as less intrusive as possible. We start at 6:30 in the morning with blood tests and ultrasound, so you don't have to miss work. We get the results in the afternoon, and then we call you on the phone to adjust the dosage and predict the number of eggs we think we'll have. So beginning to end, it's about 4 weeks, 2 weeks on the pill and about 2 weeks of injections up till the time we do the egg retrieval. And this is, again, kind of a little bit of a pictorial. You see on the top right, here's an ovary. It's about the size of one's thumb. And these little dark areas are follicles. And that's a group of cells that surround one microscopic egg. So there's only one egg in each follicle. And again, we have to stimulate the follicle growth, which you see on the right, from 5 or 10 millimeters up to 20 millimeters. It takes about 10 or 12 days. And again, women usually ovulate day 10 or 12 of their cycle. So once we have mature eggs, and again, that's very important because you have to have maturity of the egg to be able to fertilize it and retrieve it. And that final diagram down at the bottom shows a needle under ultrasound, goes into one follicle and the next and the next. Takes 15, 20 minutes to retrieve eggs. And again, it's very safe. There's very limited number of women that ever have any complications with an egg retrieval. So it's very safe. We take the fluid from the follicle, and you'll see it's collected in a glass vial, and that's then passed into the laboratory right next to the operating procedure room. And the embryologist then takes the microscopic egg from the fluid of the follicle. So here's a real nice video showing the human egg, the largest cell in the body. And you see those 2 little circles, the genetics of the sperm and the egg. And now it divides 2, 4, 8 cells. And up to about 5 days of growth, we grow embryos for 5 or 6 days till this final stage where there are about 100 cells. So as you look at it again, the fertilization, the next day it's dividing. Day 3, it's 4 cells, 8 cells. And then finally on the 5th day of growth, it's 100 cells. And at that point, we can identify fetal cells as separate from placental cells. And the embryologist then can take 1 or 2 placental cells and they go to the genetics laboratory for analysis. But that's the benefit of the 5 days of growth, is being able to select the best cells in the periphery. Now, again, unfortunately, once you start to see embryos grow, when they get to that day 3, half of them stop growing after day 3 because they're not structurally or genetically good. So maybe 1 out of 4 embryos makes it to the biopsy stage. And again, the first 5 days of growth is the first stage in the assessment of the genetics of the embryo. So that's kind of a miraculous little pictorial of how we all got to be here, starting with 2 little bits of protoplasm that grew to this blastocyst stage, and then was placed in the uterus, either with IVF or did it naturally. And in our case, we became, babies and human beings for those 2 little bits of genetic material that came together. And again, the IVF success rates 65, 75% with a genetically balanced or normal embryo. But again, the percentage of genetically normal depends on the woman's age. At age 35, 36, about 60% will be genetically balanced. By age 40, it's only 25%. By age 42, 43, it's less than 15%. So the age factor of the ovary becomes such a dominant part of this equation. And today, that's why we try to get testing with AMHs and follicle counts for women in their early 30s. There are some women in their early 30s that are beginning to diminish their egg supply. So the sooner they can do IVF and freeze eggs, or if they have a partner make embryos, the better chance of getting a genetically balanced embryo. And once we have a frozen embryo, they're good for 10 years. And we know the genetics and we know the probability of success. A genetically balanced embryo with good structure is close to 75% pregnancy rates today. And again, here's some pictures of, again, embryos and the miracle of all of this, of how you get this egg that has these two little genetic pieces inside it, and then it divides to that 8-cell stage, and then to finally that 100-cell blastocyst, and then it hatches out of its coating, you can see in that fourth picture. And the rest is kind of a diagram of how they biopsy embryos. They tease out a few cells from this 100-cell embryo, and those little red dots are where they, using a micro laser, just laser across, take those cells, and it does not damage the embryo in any way. Today, millions of embryos have been biopsied and not related to any damage to the embryo. So again, just looking at IVF success rates and what it is with undiagnosed infertility, that orange bar shows you when you don't do genetic testing, you get a 40 or 50% success rate if you just transfer an embryo into the woman that has not been genetically tested. And then you can see in blue, adding the genetic testing doubles the success rate, essentially. Here at SCRC, because we use Embryo Scope and because of the quality of our laboratory, we're certainly a little bit above the national average in terms of success rates for each age group. And again, we look at success rate costs. And today, I think, as opposed to 5 years ago, we're doing a lot less IUIs because of the cost of the IUI. With the ultrasounds and the medications and the treatment of the sperm and so on, can be $1,500 a cycle. So it gets fairly expensive. And one cycle of IVF without genetic testing is kind of more in that probably 16% or $16,000 range. And then with genetic testing and the Embryo Scope, it gets close to $18,000, which is a sizable amount. Certainly there's many national programs for financial assistance or financial programs. So here's our crew of doctors. We've actually, we see 1, 2, 3, there's 5 women and 3 men. And we have a separate site in Santa Barbara and now just newly opened in the Pasadena area. And 20,000 babies, millions of memories. We're very happy to provide what we feel is the very best in fertility care here in the Los Angeles area.
Okay. That's great. Thank you, Hal. So one of the things that sets us apart here is what Dr. Danzer showed as a little video of embryo development. That's something called an Embryo Scope, which we use extensively here. And as we talked about initially, it increases our ability to make diagnostic, um, have diagnostic embryo development, as well as embryos that are in this environment. It's a closed environment that nobody disturbs for 6 days or so. And they seem to develop better. So we get better outcomes using that. And we're the only program in Southern California area that has a number of these embryo scopes to use, primarily because they're very expensive. But they certainly do work very well. And I think that your comparison in the end of the financial implications of all of this is very important for people, because it's difficult today to afford to have children, and if you're going to do something, it's nice to do something that has a 75-80% chance of giving you a normal child that is what you want, as opposed to repeatedly doing things like taking medications and doing inseminations, which can work, but much less often, and is not inexpensive either. So I think that was an interesting way to finish. But I think Dr. Danzer and I are going to be here for a little bit. If any of the participants would like to ask us questions, we're happy to answer them.
Dr. Danzer is going to field the questions.
Okay, Hal, I think you're going to field the questions.
Right. Do I see any at the bottom of the screen? I didn't hear that last one.
He's going to field the questions.
I think you're going to field the questions. Anything? I'm just looking here. There seems to be a question that says, is IVF statistically more successful with a recent egg retrieval or frozen eggs? And that's a very good question. And it's changed significantly. The answer's changed over the last decade or so. Hal, do you want to answer that? Can you hear me?
Yeah, I'm just bringing up the question here. I'm sorry.
Sure.
I think they're asking a good question. Are we transferring fresh embryos? Are we transferring frozen embryos? And I think certainly the general rule today is to transfer embryos that have been frozen. Let the woman and the uterus recover from the stimulation process, and then come back the next month at the appropriate time to transfer the embryos. There is some advantage of transferring fresh embryos if the woman maybe only has one or two. However, the genetic testing takes 5 days of growth of the embryo to be able to then do the biopsy and assess that, so that the embryos are then frozen and the embryos are transferred the following month. So again, fresh versus frozen. Most of the time it's frozen embryos, and freezing embryo is a very established technology. The thaw rate is 98%. We rarely lose an embryo in the freeze and the thaw process. But that allows time to do the genetic testing and really assess the potential of embryos.
This question looks like it's about egg retrievals, and it does not seem to make a big difference in so much as that our rate of recovery of preserved or vitrified eggs is quite high. So it should not make a big difference in the statistical success rates of IVF between eggs that have been preserved or that are not preserved? If that maybe answers a different way to answer that question. So the next question, Sean and I had an egg retrieval, normal egg quality, no problem with any test I did. I did an ERA and pre-genetic testing as well. I'm 39 years old, did a frozen egg transfer, I guess you mean embryo transfer, and my first transfer was not successful. Well, I'm sorry that it wasn't. Unfortunately, transfers do not work all the time, but you should ask your doctor to perhaps do some testing to see if it's possible to answer the question as to why it was not successful. And there's some different reasons for that. Hal, do you want to talk about that a little bit as to why transfers don't work?
There's certainly interest today, and we hear it all the time. The question asked was, is my body rejecting the embryo? Is my immune system overreactive? And is that why I'm not getting pregnant? And there's a kind of a battery of blood tests to look at one's immune system. We certainly know that women that have rheumatoid arthritis or lupus have very elevated levels of autoantibodies, antibodies directed against their own tissue. So there is some feeling that autoantibodies may be present in some individuals and prevent the embryo from implanting. And there's different treatments for that. It's probably not a common reason. I think most of the science points to the fact it's genetics. And even with genetic testing, the pregnancy rate is not 90%, it's 70 or 75%. So there's pieces of chromosomes that what are the genetic testing involves that may not show up as abnormal in the standard genetic testing of the embryo. And again, every embryo is different genetically. And if you weren't successful with the first genetically normal embryo, the pregnancy rate should be 70, maybe 75% with the next transfer, as long as all the other testing is normal.
The other area to test is your uterus, and there are a couple of different ways of doing that. One way has to do with the cells that line the uterus, called the endometrium, which is where your embryo implants. The ERA relates to the timing of the embryo transfer, but there are other things about the lining of the uterus that may be able to be tested for prior to attempting another transfer. So that would be another idea. Hal, do you want to look at the next question about a lady who froze her eggs 5 years ago?
Yeah. And how old were you when you froze the eggs? Again, the eggs are frozen at the age they are at the time they were retrieved. If you're 5 years older, again, if you haven't frozen when you're 35 and now you're 40, there's only 1 in 4 eggs that maybe would be genetically good at 40, whereas again, at age 35, we think about 60% of embryos are normal. So I think it also would depend on how large a family you want to have. Again, if you think you want to have 2 or 3 children, you might then consider doing another round of retrieval for either eggs or if you have a partner, to make embryos.
Yeah, so Samantha, I'm going to read your question about lupus, which is what Dr. Danzer had alluded to as well, but you have no antiphospholipid syndrome. This is sort of an immune issue. And we've had, I guess it's timed relations for 9 months, then diagnosed with nephritis, which is a renal or kidney infection. Completed treatment, doing great, that's good. but your doctor recommended trying naturally for another 9 months, would we recommend being more aggressive, such as IUI or IVF, to eliminate concerns about a lupus flare? So, I think it depends upon a lot of other variables, Samantha. So I don't know how old you are, but in general, it seems like you've now been over a year trying, and then the question is should you try for another year on your own? And in general, I think it's a little bit passive an approach, and I think we would potentially recommend a more aggressive approach, depending upon some of the details of your evaluation as to whether it would be IVF or not, in terms of preventing a lupus flare. That's not something that you'd want to have affect an embryo transfer. But Hal, do you see this question?
Right. I agree. I think you don't see a lot of flares with IVF or even IUI. Again, I think the age factor is really very important in determining how aggressive to be. But I think all of these treatments are certainly an option at this point, depending on the age and how long you've been trying to get pregnant.
So the response from Samantha is she's 29 with a 3 to 4 AMH, which is really good. And what it indicates is that you're young and healthy and have a good ovarian reserve. And so, it may be true that, you don't have to be proactive immediately. But I think there's some other details that you might consider looking into in regard to your evaluation and also your partner's evaluation in order to answer that question a little bit better. So, for example, we'd like to have you do what's called a 3-dimensional hysterosonogram image to look at the inside of your uterus. We'd like him to do sperm morphology testing to make sure that he's okay. So I think the first thing that we would suggest is maybe doing a reevaluation of each of you before answering the question.
Yeah, I think the other part of the question is if you don't have a partner at 29, that's a good AMH. We always tell everyone, go ahead and do your AMH once a year. If it starts to fall, then to have a consultation with the fertility specialist about the options. It's if we only knew the future. Unfortunately, the pandemic has sort of interrupted a lot of women's potential finding a good enough partner. And time you find a partner and decide to have kids, it could be 4 or 5 years later. Freezing eggs, a lot of times is for baby number 2 or 3 when the woman is the very late 30s or 40s. But that's a good AMH, and certainly re-looking at that again yearly is probably the best thing to do. AMHs are probably more important than pap smears for young women that have already had normal ones.
So, Haley, you've inquired about how often do women have a blocked fallopian tube? And it's an interesting question. The answer is sort of it depends on who you are. So, for example, just anybody without a history of things like infections in the pelvis or previous surgeries or endometriosis or things like that, it's not often that you would have a blocked fallopian tube. If you have a history of, let's say you've had an IUD and you have had an infection after the IUD, then it's pretty common to have a blocked fallopian tube. Hal, do you want to answer that?
Yeah, I think we probably see less of our patients that have blocked tubes from infection as opposed to 5 or 10 years ago. I think that has to do with the early diagnosis and treatment of pelvic infections with and the early detection and antibiotic treatment, I think, lessens the blockage of tubes that we used to see 10 years ago. But again, if you have risk factors, so like say endometriosis or previous surgery, those are the women that would certainly want to have evaluation even before they try to get pregnant.
So Valeria asks, I'm 30 years old and been struggling for 7 years, would like to start my journey, but have PCOS, which stands for Polycystic Ovarian Syndrome. She wants to do IUI, but she's allergic to contrast and has been recommended to do the X-ray of the fallopian tube, but that is utilizing the contrast, and she doesn't want to have an allergic reaction. So she asked, what's the possibility of a success rate between IVF and IUI for polycystic ovarian patients? So that's one question. And then the other possibly related question is it true that being overweight impacts not being able to conceive? Hal, you want to take that and answer that?
Yeah, certainly there's a large number of studies looking at, weight. And again, with the pandemic, we've seen certainly a rise in weight for almost everyone. Changed our schedule of exercise and nutrition. I think when we talk about getting ready to do IVF, either freeze eggs or make embryos, there's sort of 3 things we really emphasize: is a good nutrition, Mediterranean diet, trying to get to somewhere close to an ideal weight. And that kind of involves an exercise program, which should be outlined and to work so that you really have a program so you can get to a weight that is as good as you can get it, easier for some than others. But good nutrition, exercise, weight reduction certainly improve your chance of success, and also healthier pregnancies. There's weight gain during pregnancy and problems with high blood pressure and diabetes for women that are overweight. So getting your body in the very best condition is important. And then we talk about stress reduction, whether it's acupuncture and mindfulness. Those are 2 other things that can be added to your plan that can optimize your chance of being successful with the pregnancy and also having a healthy pregnancy.
So the other thing about weight is it depends upon how much, in that, you can kind of quantify that a little bit by using BMI of over or under a certain number. For example, like 30 has been thought to be something that can be predictive of the effect of weight upon your ability to conceive. And then if your BMI is over 30, it probably is related, and it's also related to the health of your pregnancy once you do. And so if that's true for you, then it would be really good for you to try to lose some weight before getting pregnant. The success rates between IVF and IUI for polycystic ovarian syndrome patients is very significant, in that, first of all, the IUI success is contingent upon a lot of variables, including your ability to ovulate, which many patients with your condition have an issue with. You also have potential issue of some compromise in your egg quality and the ability of the eggs to produce normal embryos. With IVF, you see that, and you can differentiate between normal and abnormal embryos, and as such, it's going to give you a much higher success rate than IUI. So I hope that answers some of your questions. Al, anything else on that level?
Yeah, I mean, it's very difficult to lose weight with PCO because it's a higher androgen level. Those are women that have a great difficulty doing that. And I always recommend try to get with a program, whether it's Weight Watchers or whatever works for you, that has certain goals and people that can help you to assess those goals and help you to have the greatest advantage from a restriction of calories and exercise. And those are the two things that are most important. Some women with PCL, they lose 10 pounds and their ovulation gets a lot better and they're able to get pregnant. So it may not take a lot of weight loss, but we certainly know that the fatty tissue of the body metabolizes the male and female hormone. And if that gets balanced, it can really affect the quality of the egg.
That's the key in your situation, is the egg quality. So thank you very much for everybody's attention. I hope it was a good discussion for you. If you have any further questions, either of us would be happy to answer them for you, as would any of the other doctors here at our center. So we're very pleased to see anybody or speak to anybody individually as you like. So have a good evening, everyone.
Thank you, Dr. Surrey.
Thank you, Hal.